All right, I think we can get started. Welcome. Thank you for joining today. My name is Katelynn Cataldo, and I'll be presenting via the Concussion Legacy Foundation on concussions, post-concussion syndrome, and chronic traumatic encephalopathy. Just to give you a little background, I'm the senior nurse practitioner at the Dr. Robert C. Cantu Concussion Center at Emerson Health. That is located in Concord, Massachusetts. I've been working here for about 7 years, and here at our center, we only see concussions, PCS patients, and CTE patients. So I'm really here looking to present the best practices and guidelines of care for those who have sustained concussions, are dealing with PCS, or have been presumptually diagnosed with CTE. So let's get started. All right, so just want to review receiving credit. This is an ANCC-approved course. You receive 1 contact credit, and there are instructions in the chat as well as the email. And then participation certificates will be available at the end. If you do have any questions over the course of this presentation, please feel free to send those into the chat. People will be collecting those and then sending them to me at the end for the questions that haven't been answered, and I'd be happy to get to most of them within the time allotted. So let's start with some basics. What is a concussion? So a concussion is a type of brain injury or TBI caused by a blow, jolt to the head, or a hit to the body that results in disruption of normal brain activity. To be clear, the head does not have to be directly hit for the brain to be injured. So very often the body can sustain enough force, either to the chest, the side, the back, that results in enough force to move upward into the brain that can result in a concussion. So visualizing a concussion. Well, first of all, the brain is basically the consistency of custard or jello. So if you ever to hold the brain, it'd actually be very squishy if you were to feel it. And then the brain actually sits in cerebral spinal fluid within the skull. So it kind of actually just sits there floating to some degree. And the concussion can be sustained by 2 different kinds of forces, and I'll describe both of those. The first is a linear force, and that's a linear acceleration. So forwards, backwards. And you can see this video sort of showing examples of a linear force where the brain hits the interior of the skull, and that can result in a concussion. The second kind of force is a rotational force. And the rotational force is basically a twisting of the brain as well as the brain stem. Rotational forces are usually caused by side hits. That unfortunate boxer on your bottom right is likely going to receive a concussion via rotational force. And really what it does, it seems to be the most significant kind of concussion are the rotational forces, because there's a lot of shearing or twisting of the brain inside the skull, leading to more significant symptoms. However, most concussions do involve both forces, and that's just usually the nature of the injury. So before we talk about actual concussion, it's important to know what happens in the cells of the brain. So the neuron is the cell of the brain, and this is kind of what would happen with a regular neuronal function. So a signal arrives at the neuron, it travels down the axon, neurotransmitters are released in an organized fashion. There's a cascade of effects that, from one neuron to the next, releasing a specific coded message. And then ultimately at the end is some type of action, speaking, blinking, moving extremities. All of those things involve neuronal function. So what happens when a neuron is injured? Well, first, the neuron really can't function because the potassium just seeps out of the cell, kind of in a really significant way. Once that happens, the neuron really goes into a metabolic dysfunction, and this results in an energy crisis. So this neuron is under an energy crisis, and it's not functioning as it normally would. And this tends to lead to a massive release of neurotransmitters, which interferes with the cell communication. It's important to note, and we'll discuss this a little bit more detail in the future, that the nerve cell is really vulnerable in this condition to any type of further injury or stress. Cell damage or serious death can occur. And we're talking significant injury. We're not talking just minor injuries to the neuron. Now, it can take a few days for the nerve cells to return back to normal. And you can see kind of after several days that neuron is really going back to trying to maintain homeostasis or normal neuronal functioning. So some concussion facts that you may not be aware of. You do not need to lose consciousness to have a concussion. In fact, most of our patients in our center have never lost consciousness and still are recovering from a pretty significant concussion. You do not need to hit your head to sustain a concussion. I would say the most common is whiplash associated with motor vehicle accidents. That force is significant enough to ultimately sustain a concussion from the brain hitting the interior of the skull. Helmets are fantastic at preventing skull fractures, which could ultimately lead to intracranial bleeding, but they do not prevent concussions, and that's important to note. And concussion symptoms are not obvious immediately. So that abnormal neuronal function, it can take time for that to kind of progress after the initial hit. So sometimes patients or athletes will come off the field having sustained an injury and really report no symptoms. That doesn't necessarily negate the fact that they may have sustained a concussion. So youth athletes are more susceptible to concussions and they can take a longer time to recover. And this is simply due to anatomy. They have smaller bodies, smaller musculature, their necks are weaker, and also their brains are not fully developed. So it takes, and really they're not developed at the age of 25. So it takes time for that athlete to recover when they're younger. Females tend to experience more concussions than males competing in the same sport. And again, that goes back to purely just anatomy. Our necks are weaker. The neck is basically like the shock absorber to the brain. It really wants to take on the brunt of the force to any type of impact that our body sustains. With a weaker neck, it can't take on a greater amount of force. And then the force is basically sustained or sent upwards into the brain. Routine diagnostic imaging, such as MRI and CAT scan, will come back normal after concussion. CAT scans are really excellent for ruling out intracranial bleeds or any type of fracture within the skull or cervical spine, but they will not diagnose a concussion. In fact, nothing will, and we'll talk about that in more detail later. Leading causes of concussion, most of us tend to think sports, but believe it or not, that's really not the majority of what we see in our clinic. Falls are pretty common, particularly in your elderly population. Recreation activities, bicycling is a very common one I happen to see. Children playing in the playground, fortunately, I don't see that very much. Skateboarding, motor vehicle accidents really make up a large of our population here at the Concussion Center. Unintentionally being struck by or against an object, many construction workers during accidents, quite common, and unfortunately assaults. So what are some possible signs observed after an immediate concussion? Some physical signs that are important to be aware of would be loss of consciousness. So the person's laying on the ground or sitting somewhere and they're just completely non-responsive. They maybe exhibit poor balance or abnormalities with their coordination. They have fallen to the ground, try and get up, and suddenly they're stumbling or can't walk in a straight line. You may observe gait disturbances. Sometimes patients or athletes may widen their stance or start shuffling with their feet and just trying to remain upright. Nausea, vomiting, appearing dazed or confused, slurred speech or stuttered speech may be an indication as well. So some behavioral changes, these may be difficult to observe if you're simply just a sideline observer and you don't know the person very well, but displaying unusual or inappropriate emotions such as excessive crying, laughing, yelling, general anger, would be abnormal. Inappropriate playing behavior, so the athlete may be far more aggressive than they normally are while on the field. And showing behavior or personality changes just in general, which again could be difficult if you aren't familiar with the person's general demeanor. Some cognitive impairments to be aware of, just general confusion should raise a flag. Oftentimes, if an athlete potentially is questionable about sustaining a concussion, the sideline athletic trainer will ask them the score of the game, who they're playing against, the date, where they're actually playing, and see how quickly they can respond to those answers. Are they slow in their reaction time? Are they slow to walk off the field? Are they confused on which side of the field they should walk to? Are they even slow just to pick up their water bottle or seem really clumsy? Those may be indications of some cognitive impairment from a concussion. And also amnesia. So either retrograde or anterograde, so before or after. So if they've lost time, they can't remember events before, they can't remember events after an injury, that's a pretty classic sign associated with concussion. So these are a lot of symptoms with concussion. I would not encourage anyone to memorize them. I would just want to draw your attention to really the first two symptoms that I've highlighted here in bold. One would be headaches and dizziness. So headaches are going to occur in about 85% of patients following concussion, as well as dizziness. And there's three kinds of dizziness. There's lightheadedness, there's disequilibrium, and I described it as like you're feeling like you're on a boat. And then there's vertigo, where the room's spinning around you. And any one of those three dizziness, or I should say categories of dizziness, would count. So just being aware of those, if a patient reports that after a recent injury, it's very likely they've sustained a concussion. So some danger signs or red flags. These would definitely be something that you would want to take a look at, familiarize yourself with. I mean, as nurses, I think most of us are pretty aware of these red flags just in our day-to-day. But these are things you're going to want to either call 911 or get the patient immediately to a local emergency department for either head imaging or imaging of their cervical spine. So are they drowsy, cannot be awoken, convulsions or seizures? So those can be common, or I shouldn't say common, but they can absolutely happen immediately after a concussion, and you do not need to have history of seizures. And it's basically just the response of the nervous system due to the significant forces. They can't recognize people or places. If they come to you and they're really reporting like a 10 out of 10 headache, or they're telling you it's gotten to the point where it's absolutely intolerable, weakness or numbness or decreased coordination, and I'm really looking for upper and lower extremity numbness or decreased coordination. Those are really big red flags that you'd want to get some head imaging done right away. One pupil is larger than the other. Sometimes this can happen congenitally, like some people just have this normally, but if you see it, it should be looked at within the ED. Slurred speech, vomiting, of course, loss of consciousness, increasing confusion, restlessness, agitation, and of course, any reports of double vision. So here are some guidelines for concussion management. We use these guidelines as evidence-based practice within our clinic. So it's something that we'll send out the slide deck at the end if you're interested. So it's something that you can refer back to if you ever need some good references to go to. So treatment. Treatment of an acute concussion. We're really going to ask these patients to rest within the first 24 to 48 hours following injury, and most of them are not going to argue with you. They're tired, they're fatigued, they have a headache, they just feel general malaise, they just don't feel good. So they're okay resting. But after that, we're really going to look to actually get them moving. And I'm going to talk about that in more detail in the next few slides. We're going to provide some patient education. Patients are terrified when they sustain a brain injury. They don't want to cause any further brain damage. They don't know what they can and they can't do. They don't want to make things worse or prolong these symptoms. So some simple patient education can really help lower their angst associated with their injury, and ultimately allow them to kind of get back to their normal level of functioning. Providing homework or school recommendations. Many times, if it's severe enough, we're going to provide them with an out of work or out of school recommendation, at least temporarily until they start to feel better. And it's important that the individual should never return to activity on the day of the concussive injury. Kind of going back to that slide that I showed you about the neuron and how vulnerable it is after impact. Any additional injury could cause further damage to those neurons and could theoretically prolong the recovery and make the symptoms worse if they were to sustain any further injury. So rest. So had I been giving this presentation maybe 5-10 years ago at this point, I would have just said they sustained a concussion, they need to rest, they really shouldn't engage in any activity until they start feeling better. And then then we kind of go on and on and on. Well, now recommendations have changed. So we want them to rest for the first 24, 48 hours. But after that, we want to really focus on a gradual and a progressive return to daily activities. We don't want them to return to these activities so they're in a fashion that they're having severe symptom exacerbation. But some slight increase in symptoms is okay. The research has really shown that complete, strict physical rest or even cognitive rest has been shown to be ineffective and potentially hazardous following concussion, and is really no longer recommended. So circling back to kind of the research. So when we're talking about activity, we really focus on aerobic exercise. And it was shown that early initiation was associated with a faster full return to sport and school or work. So within those 7 days post-injury is when we're focusing on trying to get them back into some light aerobic activity. That's usually walking either outside on a treadmill or using a stationary bike. So treatment recommendations. Treatment recommendations definitely vary when it comes to concussions, and it's based off how the patient's symptoms, how they respond to particular activity. But here's some examples that we provide to our patients when they do sustain a concussion. We may offer or suggest limitations with screen use, which is pretty common. We may ask that they recommend or, reduce reading or schoolwork. And then we always typically place limitations on physical activity. We want them to move, but we don't want them to start returning back to their practicing 5-mile runs, sprints, things of that nature, until we've established that they're more in sort of the recovery profile. We may provide adjustments to school or work by printing electronic material to avoid prolonged reading on the computer. Typically, a shorter workday or school day is going to be utilized in the early days following a concussive injury. We're going to schedule breaks and ask them to go to a quiet place. Usually the breaks don't need to be long, 10 to 15 minutes will do the trick. And it will allow their symptoms to kind of calm down, allow them to come back down to their baseline, and then hopefully they can return back to either their school or academic work, or school or their occupation. And allowing extra time to complete tasks is really helpful. Usually these patients have some level of cognitive dysfunction. They need a little bit extra time. And then modifications, that's usually around electronic media. So changing contrast and brightness or enlarging font, just to help some of the strain on the eyes that can occur. So patient family education's kind of a lot of what I do in the clinic here. I would say 50% of my visit I spend on education. I want the patient to leave knowing exactly what's happening and how that relates to symptoms. Patients are usually terrified that they are causing further brain damage when they're doing particular activities or they're making their concussion worse. In many cases, that's actually not true. But I want to reassure them that what they're doing is okay. It's going to help progress their improvement. And ultimately, they're likely going to be just fine and fully recover. Concussion symptom management. So I'm advising them to stay within their sub-threshold level of symptoms. What I mean by that is I want them to engage in activity. They might have some minor increase in symptoms, but they're certainly not leaving, the classroom with a 10 out of a 10 headache. That's not our goal. We talk about proper posture, which can help reduce neck strain, use of medications, particularly over-the-counter medications for management of headaches or neck pain. Heat, I didn't add this in, but ice can actually be incredibly helpful for management of headaches. There's something out there called an ice helmet. A lot of our patients use it. They'll put it on, it kind of covers the entire head, and it really helps to reduce the pain. Managing environment. So excessive environmental stimuli can very easily cause increase in symptoms. So turning down bright lights, moving to a quieter room, maybe putting on some noise canceling headphones, all of those things can be helpful. Avoiding further injury, including no contact sports. And then we're always going to provide some type of graded return to activity, again, focusing on some light aerobic activity and then progressively building as tolerated. And we'll talk about that in more detail in a little bit. So now we're going to switch gears from concussion to post-concussion syndrome. So about 85 to 90% of concussed athletes will heal from their concussion within 1 to 2 weeks, but that 10 to 15% will go on to develop post-concussion syndrome. That's defined as 3 or more of the following symptoms listed below, lasting greater than 4 weeks. And the key is with or without exertion. So sometimes patients will feel really well while at rest, but then when engaging in either physical or cognitive activity, symptoms of concussion can start to spike. So here you're going to find the symptom domains associated with post-concussion syndrome. It includes the vestibular dysfunction. Oftentimes patients will report dizziness, vertigo, disequilibrium, lightheadedness, nausea, ocular motor dysfunction. So they'll report blurred vision, double vision, difficulty focusing. Usually acuity is perfectly fine. So if they were to go to their optometrist, they wouldn't need new reading glasses or lenses for distance, but they're having trouble looking at screens, scanning, scrolling. It's really the functioning of the eyes that tends to be disrupted. Cognition can be abnormal, and that's usually issues with memory. Mostly I see short-term memory, and then attention, concentration, focus, retention is very common. Somatic symptoms, including headache, neck pain, light noise sensitivity, ringing in their ears. Sleep is a big one. If they're not getting good sleep tends to be the most restorative activity for the brain. So if they're not getting good sleep, they're certainly having difficulty recovering from their concussion. Patients may report insomnia, trouble falling asleep, or they may report excessive sleep, which can happen. They also may report disruption in circadian rhythm. So they're having trouble falling asleep at night, but then sleeping for most of the day. Mood, anxiety, depression, increase of premorbid diagnosis of anxiety or depression, just general lethargy, apathy is pretty common. So I just want to walk you through what we do here at the Concussion Center, because it's kind of just unique in general. So what we do is we start with a comprehensive patient history. We really like to detail the current brain injury, starting with the date of the injury, so when they sustained the injury, also their mechanism or mode of injury, how did they get it? Then we want to discuss immediate symptoms they had at the time, and then current symptoms. Was there loss of consciousness at the time of the injury, amnesia? Some of these things can be predictive factors for a more prolonged recovery. Have they seen any physicians or medical doctors, either primary care in the ED, and has any brain imaging been done? What are their triggers that increase their symptoms? School, work, exercise, sleep, screens, all of those are important to note, particularly when coming up with a plan. So we want to categorize and take a look at their medical history as well as their family history. Any premorbid diagnosis listed here tends to increase in a post-concussive state and can certainly complicate recovery. Depression, anxiety, migraines, ADD or ADHD, dyslexia or any diagnosed learning disability, seizure disorder, or any other general psychiatric disorder. So we're not going to treat these premorbid conditions, but we really want to make sure that they are with a professional that can help manage these premorbid conditions through the course of their concussion recovery. and of course, any type of medications they're on and allergies. So we do a comprehensive neurological exam. We take a look at mentation, motor, cerebellar functioning, balance, and then of course a full cranial nerve evaluation. But in addition to that, we do a focused concussion exam. So I had mentioned that ocular motor functioning is common. So what can happen is the actual functioning of the eyes, tracking, scanning, focusing is usually disrupted in a post-concussion state. So these three areas and those bullet points, look at those in more detail to determine if we need to send them to any type of vestibular or visual type of treatment. Balance testing. So we use the balance error scoring system, which is a standardized way of looking at postural instability. And then a cervicogenic assessment. So basically we're looking at the cervical spine. Is there any potential for injury, pain? What does that look like? Could it be causing headaches? Could there be dizziness involved from the neck? So we do a pretty thorough cervical spine evaluation. So as I had mentioned, there's really no objective way to diagnose a concussion. An MRI, a CAT scan can come back normal. Unfortunately, there's no lab test to rule in or out concussion. So at our center, we use a comprehensive symptom checklist that we ask the patient to fill out every time they come at the initial evaluation and then any subsequent follow-up. And we really use this symptom checklist to track progress over time. And you'll see here it's 26 symptoms. If you look a little bit closely, we did organize them in a domain fashion. So if you look to the left of the page, the top 6, I believe, is cognitive symptoms. The bottom 7 is somatic. Then off to your right, the top 4 is vision and vestibular. The middle 5, I believe, is sleeping. And then the bottom 4 is mood. And it really just helps the clinician to take a look at this symptom checklist quite quickly and just see what domains is the patient most impacted by. So other than time, rest, over-the-counter medications, what can we do to help treat a patient with concussion? And actually, in fact, there's a lot we can do. So rehabilitative therapies are really our first line of treatment. This includes physical therapy. Our physical therapists can treat vestibular deficits, so that issue related to balance, vertigo, disequilibrium. They can treat the neck. So the neck can cause a number of issues, not just neck pain. It can contribute to headaches. It can contribute to dizziness. So really doing a thorough neck evaluation and then treatment can be helpful. Towards the end of the patient's treatment, they'll also work on strengthening of the neck and spine, which can help reduce risk of injury, because remember that neck is like the shock absorber for the brain. And then our therapists have developed a return to activity protocol. It's basically a prescribed exercise program for concussed individuals who were maybe very active prior to their injury, but are having trouble getting into high exertional aerobic activity without provoking their symptoms. Occupational therapy. Our occupational therapists will, here at our center, only do vision therapy. So they'll work on that vision function. They're also really instrumental in providing accommodations for work and school. And basically it's to allow our patients to get back into either school or work sooner than they probably would have had they not had those accommodations in place. Cognitive therapy, this is done by a speech language pathologist. They'll evaluate and treat cognitive dysfunction. They'll formulate school and work plans. And again, they're quite instrumental in allowing our patients to get back to school or work sooner than they likely would have if we just relied on time. So here's an example of a graduated return to school strategy. This is adapted from the Berlin guidelines. You'll see that it's a series of 4 stages with goals and activities directed at each step, starting with the child doing activities at home for short periods of time, and then progressively building once they reach each goal. My only issue with this graduated staging return to school is that it really suggests that the child should be symptom-free before building to each or then going to each stage. And that's just not really how we function here at the Concussion Center, because unfortunately, if we had that, the patients could be home for 4 to 6 weeks, and we just don't want that to happen. So we'll do a progressive return as quickly as we can to try and get them to at least school part-time, so they can get into their environment, get into a schedule, see their friends. Isolation is a really bad thing that can happen with some of these concussion patients. So we want to reduce kind of those external factors as much as we can. But this is a very helpful guideline. So return to classroom, it certainly needs to be gradual and controlled. Remember, these are kids. We need to, and we understand that the younger they are, the longer their recovery may possibly be. So here are some list of academic accommodations. By no means do we give all of these to every student. We really tailor them to meet their needs, and something that you can reference if you'd like to in the slide deck in the future. So a graduated return to sports strategy, this is also adapted from the Berlin, or this is actually from the Berlin guidelines. And you'll see that this also goes into stages up to 6. At our center, we really can progress them pretty quickly up until stage 4 while they still have symptoms. Now, understanding that they're not having 10 out of 10 headaches or 10 out of 10 dizziness, they're tolerating these activities, but they have symptoms to some degree during the course of the week. Where we have a hard, strict no is they are not to return to any type of full contact practice or return to sport until they are absolutely fully recovered from their concussion. And that needs to be established by having no symptoms while engaging in both physical and cognitive activity. So they need to be exercise or symptom-free and in school or work symptom-free before we can even consider them returning back to contact play. And really, they need to be symptom-free for a consecutive period of days. It can vary. A patient that sustained a concussion and they recovered within a few days and had no symptoms, they can usually get back pretty quickly, versus a patient that maybe had 3 months of a post-concussion syndrome. We're going to want to make sure they're symptom-free for a good probably 2, 3, 4 weeks before we're considering returning them back to full contact practice or play. Return to work. So unfortunately, there's not a lot of evidence-based research about returning to work for those who sustain concussion. There's a lot about athletes, but not about really adults, unfortunately. So the majority of individuals, between 73 and 88%, who sustain a concussion will return to their principal occupation within a year. Both physical and cognitive activity, cognitive rest is important with acute injury, but when is the optimal time to start the return to work process? And that's something that we still haven't perfected. It's something that we work on day to day, and we use our team, physical therapists, occupational therapists, cognitive therapists. But unfortunately, there's really no set time when it's most appropriate to send the patient back to work. Often patients will continue to experience symptoms when resuming pre-injury activities. This tends to lead to increase in stress and anxiety. So our job is really to reassure them that they're doing the right thing. They're not causing damage. They're not prolonging their recovery. And that usually helps quite a bit. So issues faced when returning to work, it's an invisible injury. So usually they show up to work, they look fine, and their coworkers tell them that, not in a mean way, but they say they look great, but yet they are struggling internally. The symptoms affect the patient's ability to do their job, so they may not be as productive as they once were. And there's clearly just a lack of guidance during the return to work process, which can obviously lead to a lot of trouble. And these are just some factors that are associated with poor functional outcomes. It includes dizziness, post-traumatic stress, just a significant number of symptoms at each subsequent follow-up, cognitive impairments, reduced social interaction, any type of pre-existing mental health issue, lower premorbid intelligence, and sometimes we do, very rarely, but we do see financial compensation seeking. So consider the following when returning to work. Is the patient capable of returning to a specific job? What supports or accommodations or compensatory strategies are needed? If they can't return to their specific job, do they have access to modified job duties or an alternative job? We utilize that quite often. So the patient may do some like simple paperwork or something like that, or help their boss out and maybe not do their exact job, but they are active, they are going to work, they are getting paid. And then as they progressively return back to their baseline, they can return to their previous occupation. Is there risk of re-injury? If so, they should be fully recovered before returning to work, or safety restrictions should be in place. There's occupations that we kind of have to treat them just like they are a contact athlete. Correction officers, behavioral health specialists, their risk of re-injury is very high. So they really cannot go back to full duty unrestricted until they fully recovered. Police officers, EMTs, things of that nature, firefighters. So if they're unable to return to work, of course, we're going to utilize that rehab therapy that we talked about. Neuropsychological testing can be very helpful in protracted cases. So people that have had symptoms for longer than 6 months to a year. Vocational counseling or rehab. Vocational counseling can be incredibly helpful because they do assessments, they provide education, they can really help the patient kind of guide them into a new occupation without having to navigate on that on their own. And of course, during the course of their rehabilitation, we're always encouraging volunteering, exercise, reading, and really probably one of the most important things is socializing. Isolation can be quite detrimental. So medications, as I mentioned, therapies are always first line. We do have medications. However, if the patients are either refractory or maybe they just need some additional help. So medications that we use, amitriptyline, nortriptyline, you may be familiar with this. It's used in many, many disciplines within medicine to treat pain in general. It's a tricyclic antidepressant. We're obviously not treating their mood. We're starting at 10 milligrams, which is a very low dose. We're typically asking them to take it at night. And then we're gradually increasing the dose as tolerated. I'd say the max that we'll go up to here is about 40 milligrams, but have seen other neurologists go as high as like 75. You can give this to adolescents and adults. You should be avoided in patients with obesity and heart disease. So side effects are pretty common with this medication, but the most common side effect is drowsy and sedation. I actually use that to my benefit because most of our concussion patients have some type of sleep disruption. So I can treat their headaches and hopefully help their sleep at the same time. Topiramate or Topamax, it's an anticonvulsant medication that has also been shown to be helpful for headaches. We typically start pretty low and then gradually build. We start at 25 milligrams at bedtime, and then the goal would be 50 milligrams twice a day. But if we find kind of a sweet spot in there where the patient finds their headaches to be more manageable, they don't need to reach that dosage. We don't want to stop it abruptly. We do want to taper it off to prevent rebound headaches. No alcohol. Actually, and it can reduce the effectiveness of estrogen-based birth control. So patients need to be aware of that and use an alternative contraception. Side effects include paresthesia, drowsiness, dizziness, memory impairment, weight loss. Those side effects are not as common as the kind of the drowsiness with the amitriptyline. Gabapentin, or otherwise known as Neurontin, which I'm sure you're aware of as it's used in also many, many areas of medicine for pain management. It is also an anticonvulsant. We typically start pretty low, 100 milligrams. I always give it at night just in case it does cause some sedative side effects. And then you can increase with a goal of about 300 milligrams at bedtime. It's a nice medication because you have the ability to use it throughout the day if it doesn't cause any fatigue or drowsiness, and it can be pretty effective. You also do need to taper off this medication. We don't have the patient abruptly stop it. Central nervous system stimulants. These we use very sparingly. Typically, I want a patient to go through cognitive testing as well as neuropsychological testing before we really even discuss the use of a stimulant. And why? Because neurostimulants will work for just about everyone. So you don't need to have ADHD or cognitive disruption for a neurostimulant to work. And it can be highly addicting, meaning you can start taking it and feel like you need it to function within your day. So usually we'll start with a short acting, methylphenidate, immediate release, or Ritalin, about 5 to 10 milligrams once to twice a day. And we don't want them to take it late because it can disrupt sleep. Usually it has a pretty short time frame that it works. It usually only works for about a good 4 hours. If it helps, but let's say the patient needs a more prolonged benefit, long-acting methylphenidate or Concerta is pretty helpful. Side effects: anxiety, heart palpitations, high blood pressure, insomnia, reduction in appetite. Headaches can happen, although admittedly, I don't see them happen that often. All right, so now we're going to shift into chronic traumatic encephalopathy. So a little bit of history of CTE. CTE was first observed in 1928 by Dr. Harrison Martland. He observed a condition in boxers called punch drunk. At the time, he hypothesized the symptoms were directly related to repetitive blows to the head. Years later, after research, he found that it was a disease marked by motor deficits, cognitive and mood dysfunction, and he termed it dementia pugilistica. So CTE is a neurodegenerative disease, meaning once you get it, it unfortunately just continues to get worse. And it's really thought to be caused in part by repetitive brain trauma. Now, this can be caused by mild traumatic brain injuries, but really, I think the sort of core cause of this is subconcussive injuries. And basically what that means, it's mild brain trauma that doesn't result in symptoms of concussion. So basically it's that brain that's sitting in that fluid, just impacting the skull at more lighter impacts, let's say, or forces than, say, a concussion. But these repetitive injuries happen many, 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 many times over the course of even just a season. And this can accumulate over time, leading to trauma. So I want to be clear that CTE is very, very distinct from post-concussion syndrome. And if you take away one thing from this presentation, I'd like you to take away this. Symptoms of CTE do not present themselves until years later after the trauma-producing activity. So the typical course of what we have seen will be, I'm going to use football players as the most common. The football player will play their career, say they play into college, then they retire, they go on, they have a very successful business or career, something of that nature. They feel great. They have no issues related to cognitive dysfunction or any symptoms associated with CTE. And then around 50, 60 years old, and that varies, but around that time is when they'll start to see some slight symptoms of cognitive dysfunction or mood alteration, and then those symptoms will get progressively worse. Pathologically, CTE is characterized by an accumulation of specific tau proteins. And to be clear, this can only be definitively diagnosed in postmortem, and that would be on autopsy of the brain. Populations affected by CTE, American football players are #1 by far. Certainly boxers are too. There just happens to be more recorded football players right now in the brain bank at Boston University. Wrestlers, hockey players, unfortunately victims of physical abuse, epileptics, and there have been recorded soccer players, although it's not the majority of the population. It's been observed, that the repetitive, or believed that the repetitive head trauma appears to start a cascade of events in the brain that eventually leads to progressive destruction of the brain tissue. So neuropathology of CTE, I just wanted to kind of show you this real quick. Brain damage and buildup of that tau protein I had mentioned is seen within the cerebral cortex. So you kind of have an idea of what that looks like off to the right of your screen, kind of in that gray matter, and it's located all over the entire cerebrum of the brain. And then also within the medial structures of the limbic system, and that's off to your left. You'll find that in the amygdala, the hippocampus, the hypothalamus, as well as the thalamus. The symptoms become more severe as the neurodegeneration progresses. So here you're going to see some slides, starting with a normal looking brain on autopsy, all the way up to severe CTE. So on the top, you're going to see the red areas stained. Those are tau proteins, but you can also just see that the general sulci, and those are those indents or divots within the brain, are significantly atrophied. And there's also a lot of tau protein, which is dyed red, as I said, particularly in the severe CTE section. The bottom are some microscopic views of severe CTE. And again, the red areas are tau proteins. So clinical presentation of CTE, there's 3 specific domains, a little bit different than concussion and post-concussion syndrome. The first being cognitive. So memory impairment is quite frequent, but usually what we're seeing is executive dysfunction early on. So this is a really successful individual who maybe has had a thriving career, highly organized, and suddenly they're just unable to problem solve or multitask, or once they were very organized person and now kind of their office is in shambles, or they keep missing meetings and things like that. So it's small changes that start, but it gets progressively worse. Mood, depression is very common, apathy, irritability. Behavior, impulse control is kind of a hallmark symptom associated with CTE. Aggression and increased violence, which can be quite troublesome, particularly for family members and caregivers. And then substance abuse or other addictions, gambling tends to be one of them, drug abuse, anything of that nature is quite common in this population. So management of CTE, so there's no treatment, just to be clear. The treatment really just consists of symptom management, basically. So we're always going to start with the basics: lifestyle interventions, exercise, which can help improve cerebral blood flow. Aerobic activity has also been shown to improve neurogenesis, so building of new neurons in the brain, and then neuroplasticity. Diet is important to maintain a really well-balanced diet with protein and high consumption of fruits and vegetables. And then certainly the treatment that we had discussed prior related to post-concussion syndrome, cognitive rehab, vestibular rehab, occupational therapy, and then the behavioral health or therapists, psychotherapists, things of that nature can be instrumental in helping these patients cope. Pharmacology, there are no FDA-approved treatments for CTE. And really, if a person has suspected CTE, they need to be seeing a specialist. That specialist is going to be reviewing all medications that they're currently on and trying to either remove or minimize any medications that cause cognitive impairment. These include anticholinergic meds, antihistamines, narcotic pain medications, benzodiazepines, sleep aids, and muscle relaxants. So pharmacology, again, is really just aimed at treating the symptoms. So cholinesterase inhibitors or Aricept or Exelon to treat memory impairment, Sinemet or amantadine for apathy, Adderall or Ritalin, those neurostimulants for impaired attention, and then SSRIs such as Zoloft or Lexapro for depression, anxiety. They actually can also be used to help treat agitation. So CTE is a progressive disease. Unfortunately, once someone develops it, it will progress. And it is incredibly impactful onto the patient, but really, really quite devastating for the family and the caregivers because they just watch their loved one sort of progressively deteriorate cognitively, mentally, physically. So trying to provide them with as much support as you possibly can is probably the most important thing that we can do. Some resources I have listed here. Of course, the Concussion Legacy Foundation is an excellent resource. They have the CLF helpline, and their website is just wonderful at kind of guiding you to areas that you may be interested in or find helpful. Your local Brain Injury Association and the Alzheimer's Association as well too. All right, so that concludes my presentation. Thank you for listening. I'd be happy to answer any questions that have come in. I'm just going to review them quickly. There was a slide here for receiving credit. Just to review, if anyone had come in late, there is one contact hour from the ANCC. Those instructions are going to be in the chat as well as the email. So just head there for any further direction to claim your credit. Okay, so question, how about screen use when PCS is 6 months in, improving but setbacks with increased anxiety, depression, and fatigue? What is the best practice? So I think what the question is asking is like, patient is 6 months in, post-concussion syndrome. They're trying to expose themselves to screens, but they are, I don't want to misinterpret this. But they're also dealing with issues related to anxiety, depression, and fatigue. So I tend to, particularly 6 months in, be pretty liberal, about my screen usage, because how else does one function without screen exposure in the world that we live in these days? So if it causes symptoms, what I'm going to tell them is they can use the screens, they can watch TV, they can look at their phone, but let's say headache, right? So if they start looking at their phone and their headache is a 2 out of a 10, when their headache goes 2 points above where they started, so it goes to about a 4 out of a 10, is when I want them to take a break. They take a break, they shut their phone down, maybe they go do a different activity, they walk around, fold laundry, I don't know, do some household chores, whatever. But then they can go back to their phone or go back to their computer or go back to watching TV. And hopefully over time, they'll be able to progress that level of tolerance. So they certainly don't need to massively restrict screens 6 months in. I just don't know how we would expect them to function. And obviously best practice when they're having setbacks with anxiety, depression, fatigue is you need to have them see a psychiatrist who can aggressively treat that anxiety and depression. I could almost guarantee you're going to note pretty good improvement in symptoms with treatment of those conditions. All right. Can you explain second impact syndrome and others returning of risk of returning to play with concussion too early? Yeah, sure. So second impact syndrome, so I had mentioned that those neurons are really vulnerable to injury at the time, or shortly after the concussion. So it's very, very rare, I want to be clear, that second impact syndrome, but it does happen. And basically what can happen is there's been these case reports that an athlete will sustain an injury. No one really picks up on the fact that they've had a concussion. They continue to return to play in the game, or maybe the following day they return and play in the game. They're hit again at a pretty intense level, and then they go on to develop second impact syndrome. And basically what that is, it's a massive neurological and brain dysfunction, which can lead to swelling of the brain. Unfortunately, it has led to death in a few instances. So that's obviously something we want to avoid at all costs. It is incredibly rare. I want to be clear on that. That's not the norm. But also what can happen, I just saw an athlete today who sustained a concussion. She didn't think much of it, probably just wanted to continue to play, tried to play through it over the course of the next few days. Symptoms continued to increase. Remember, those neurons are very sensitive to any additional impact at that point. And now we're already 6 weeks into her recovery and we're really not getting any better. So multiple impacts within a short period of time after a concussion can absolutely lead to a more prolonged recovery and also worsening of symptoms. What should we tell post-concussion syndrome patients whose symptoms become significantly worse with rehab therapies weeks and months after injury? So, I mean, hopefully as you're working with the rehab therapist, you're kind of giving the feedback to those therapists and they can adjust treatment accordingly. Certainly I have patients whose symptoms worsen significantly, and sometimes we need to take breaks. Sometimes we need to manage other symptoms such as like pain management. We need to get the pain under control before they can consider going back to therapies. So there's no guideline in how to do that, but I think it's important just to take a look at how the patient's functioning, what specifically is causing their symptom increase, and how else can we treat that effectively? Or do they simply just need a break? And what concussion screening or diagnostic tool do you use in your clinic? So we use the Dr. Robert C. Cantu concussion checklist that I had shown earlier, and that will be in the PDF file. We typically use that, and then we don't really use a screening tool, to be honest. There are some out there like Impact, SCAT. There's a whole bunch. We don't use them because we're seeing them for such a significant comprehensive evaluation that we usually can determine, whether or not they've sustained a concussion within that evaluation. All right, and it looks like we have one more question coming in. And then maybe we'll get close to 4 o'clock so we can wrap up. In high school sports, there are recommendations to stop higher risk sports after so many lifetime concussion diagnoses. Is there a number that you say no more, football, hockey, et cetera? Yeah, excellent question. I get this all the time. So I have so many athletes that come in that are just terrified to see me because they have had 3 lifetime concussions and they've been told by Dr. Google that they have to retire. And that is not true. So there's no, so unfortunately, there is no good firm clinical research, like randomized control trials or anything like that, excuse me, to address retirement. Now, we do not follow the 3 and you're done rule. We really try and look at the injury or their history as a whole. Have they recovered from each injury? What length of time have they recovered from that injury? Did they have any prolonged deficits, prolonged cognitive issues related to one injury? How many have they had? I mean, are we looking at, have they had 10? If they've had 10, we really need to talk about retirement. Are they starting to sustain concussions at lower impacts? A perfect example I see quite a bit are female soccer players. They've been heading the ball their entire life, no problems, no head injuries, right? And now they're heading the ball and they're sustaining concussions. That's a red flag that their brain is now more vulnerable to impact. In those cases, we absolutely need to talk about retirement. So it's a great question. We do not have a specific number of lifetime concussions before you should retire. It's really taking a look at the patient as a whole and seeing, have there any evidence of deteriorating from a neurological perspective from concussions? If the answer is yes, they need to retire. If the answer is no, they retire quickly, and maybe they've had 3, then likely they can continue to go on and play sport. All right. Last question, would you recommend the SCAT as a useful tool? Yeah, absolutely, I would. We don't use it here. It's an excellent sideline tool. It's an excellent in-clinic tool, particularly if you're not dealing with concussions on a regular basis. Yes, it's comprehensive. It addresses most of the things that we do in our office. So I think it's probably one of the better assessments, to be honest, to either rule in, rule out concussion, and also track concussion. So kind of the course of the patient's recovery. All right. Well, I think that brings us to 4 o'clock. I just want to thank you all for joining. It's been an absolute pleasure. If you have any questions, you can feel free to reach out to me. Maybe there's a way I can get my email out there. I'd be happy to answer any questions that you may have. And I wish you all the best of luck, and thank you for joining.